Welcome to Chapter 2. This chapter introduces a structured approach to diagnosing retinal and choroidal disease. Accurate diagnosis begins with careful clinical evaluation and is refined through the thoughtful use of ancillary testing, with each modality contributing distinct and complementary information. Throughout this chapter, we will review the strengths, limitations, and appropriate clinical applications of commonly used diagnostic tools, including ophthalmoscopy, fundus photography, optical coherence tomography, angiographic techniques, and ultrasonography. The goal is to emphasize a multimodal, hypothesis-driven approach, but allows precise localization of pathology, assessment of disease activity, and informed clinical decision-making. Let's get started.
Let's begin this chapter by talking about the initial retinal evaluation, which begins with a thorough history, including family history and a review of systems, and is followed by a comprehensive ophthalmic examination. This step establishes the clinical context that guides further assessment. The clinical examination includes measurement of visual acuity, careful evaluation of both the central and peripheral retina, and assessment for the presence of a relative afferent pupillary defect. Additional in-office testing may be performed, including use of the Amsler grid to detect evidence of macular disease. Building on the clinical examination, imaging plays a central role in diagnosis. Diagnostic testing is guided by clinical findings, as no single imaging modality provides all necessary information. Instead, each modality contributes distinct and complementary data. For this reason, integration of multimodal imaging is essential for achieving an accurate and efficient diagnosis of retinal and choroidal diseases.
Building on the general principles of clinical evaluation and imaging, ophthalmoscopy remains a core component of retinal examination. Direct ophthalmoscopy produces an upright monocular retinal image with high magnification of approximately 15x. However, its lack of stereopsis, limited field of view of about 5 to 8 degrees, and poor visualization of the retinal periphery significantly restrict its utility. For these reasons, direct ophthalmoscopy now has limited clinical use and has largely been replaced by indirect techniques. Indirect ophthalmoscopy addresses many of these limitations by directing light into the eye through a condensing lens, creating a flat, inverted, and laterally reversed aerial image between the lens and the examiner. This can be performed using a binocular indirect ophthalmoscope or at the slit lamp with a condensing lens, with multiple lens options available to tailor the examination to clinical needs. Magnification is determined by the dioptric power of the condensing lens and is calculated as -60 divided by the lens power. For example, a 20 diopter lens provides approximately 3 times magnification, with the negative sign indicating image inversion.
Building on the limitations of direct ophthalmoscopy, binocular indirect ophthalmoscopy offers a more comprehensive assessment of the retina. This technique produces an image that is both inverted and laterally reversed, but it provides several important advantages that make it the standard method for peripheral retinal examination. A key advantage is stereopsis, which allows depth perception and improved assessment of retinal pathology. Binocular indirect ophthalmoscopy also provides a wide field of view, which varies depending on the power of the condensing lens used, with higher power lenses yielding a wider field but lower magnification. With appropriate ocular steering, the entire fundus can be visualized, and with full pupillary dilation, the ora serrata may be seen without the need for additional instruments. The use of scleral depression further enhances this technique by enabling detailed examination of the peripheral retina. Despite these advantages, there are limitations. Compared with direct ophthalmoscopy, binocular indirect ophthalmoscopy provides lower magnification, and the inverted and reversed image orientation can make interpretation less intuitive, particularly for inexperienced examiners.
Another commonly used indirect technique is slit lamp indirect ophthalmoscopy, which combines the optics of a non-contact condensing lens with the magnification of the slit lamp. This examination is typically performed using a 60 diopter or 78 diopter lens and leverages the slit lamp's magnification, generally in the range of 10 to 16 times. Ocular steering allows the examiner to visualize a large area of the fundus. The choice of condensing lens influences both magnification and field of view. With a 60 diopter lens, lens magnification is approximately 1 times, with a field of view just under 70 degrees. A 78 diopter lens provides a wider field of view, greater than 80 degrees, at the expense of lower magnification. Higher dioptric power lenses further expand the field of view, up to or exceeding 100 degrees, and are particularly useful in patients with poor pupillary dilation. Key advantages of slit lamp indirect ophthalmoscopy include wide-field fundus visualization and the absence of corneal contact, which allows subsequent imaging without interference. The primary disadvantage is that, as with other indirect techniques, the resulting image is inverted and laterally reversed.
When higher resolution visualization is needed, contact lens fundus examination provides distinct advantages by neutralizing corneal refractive power and astigmatism. This allows very high-resolution views of the fundus with minimal magnification. However, these lenses require the use of a viscous coupling fluid, which can interfere with subsequent imaging and must be considered when planning the examination sequence. Several types of contact lenses are available, each suited to different clinical purposes. A central lens provides a direct view of the posterior pole with a field of view just over 20 degrees. 3 mirror lenses allow evaluation of the mid-periphery, far periphery, and iridocorneal angle. These lenses produce a non-inverted image, but each mirror has a limited field of view, requiring lens rotation to visualize the full 360 degrees of the peripheral retina. Wide-field contact lenses offer an alternative approach by allowing visualization of peripheral pathology with fields of view up to approximately 160 degrees without the need for lens rotation. These lenses produce an inverted image, but are particularly useful when peripheral visualization is otherwise limited. Ultimately, lens selection is guided by clinical need. For example, wide-field lenses may outperform 3 mirror lenses when posterior capsule opacification restricts peripheral retinal visualization. As the examination moves beyond direct visualization, ancillary testing is an important tool in ophthalmology. Fundus imaging provides a reliable method for documenting retinal findings. Fundus cameras use flash illumination to obtain high-quality images, allowing detailed assessment of retinal pathology. Color fundus photography serves as a cornerstone of retinal imaging. It provides permanent photographic documentation for clinical records and is widely used in research and teaching. In addition, it forms the basis of many large epidemiologic and treatment studies. Color fundus photographs offer excellent color accuracy, low image noise, and high resolution, making them well-suited for longitudinal follow-up and comparison over time. Fundus imaging can be further expanded through the use of filters, enabling additional modalities such as fluorescein angiography, indocyanine green angiography, and fundus autofluorescence. These techniques provide complementary information about retinal and choroidal structure and function that is not visible on standard color photography alone. There are, however, important limitations. Cloudy ocular media can cause increased light scatter, which reduces image contrast and obscures fine fundus detail, limiting image quality in certain patients. The accompanying figures illustrate the value of multimodal fundus imaging. Panel A shows a color fundus photography demonstrating geographic atrophy with refractile drusen, with a white box highlighting an area of interest. Panel B is a magnified view of that region, revealing detailed refractile diamond-like particles corresponding to drusen material. Panel C shows a fundus autofluorescence image, demonstrating reduced autofluorescence in areas of geographic atrophy and absence of autofluorescence at the locations of refractile drusen, highlighting how different imaging modalities provide complementary diagnostic information.
Moving from flash-based photography to laser-based imaging, scanning laser ophthalmoscopy functions as both an ophthalmoscope and a fundus camera. Images are generated by scanning a focused laser spot across the retina in a raster pattern, with image construction based on a Maxwellian view system. A major advantage of scanning laser ophthalmoscopy is its confocal design. This allows rejection of scattered light and fluorescence, improving image contrast and permitting the use of shorter wavelengths. As a result, this technology supports applications such as fluorescein angiography and fundus autofluorescence imaging. Scanning laser ophthalmoscopy also offers significant wavelength flexibility. Multiple wavelengths can be selected based on clinical need, and fundus images can be reconstructed from blue, green, and infrared lasers. This produces multicolored images that differ from the appearance of traditional color fundus photography, but provide enhanced contrast and complementary diagnostic information.
Building on the core principles of scanning laser ophthalmoscopy, or SLO, specific SLO modalities further expand diagnostic capability. Infrared imaging can be used alone to evaluate the fundus and may reveal abnormalities that are less visible on color fundus photography. Findings such as pseudodrusen or choroidal nevi may appear bright on infrared imaging due to increased infrared reflectance. Scanning laser ophthalmoscopy also supports angiography and autofluorescence imaging. Fluorescent angiography is performed using intravenously administered fluorescin as a contrast agent. In contrast, fundus autofluorescence does not require dye and instead uses an excitation laser with a barrier filter. Blue-green wavelengths are absorbed by macular pigment, influencing the autofluorescent signal. Ultra-wide-field SLO systems, which use ellipsoidal mirror designs, further extend retinal visualization. These systems provide a field of view of up to approximately 200 degrees, allowing imaging of nearly the entire retina with ocular steering. Pseudocolor images are generated using red and green lasers. However, there are important limitations. The color appearance is unnatural, and lesion color must be assessed clinically. Confocality is limited. Images are not recorded at video rates, and a green laser is required for autofluorescence imaging.
To illustrate how scanning laser ophthalmoscopy compares with other imaging modalities, this slide presents images of the same healthy eye obtained using 3 different techniques. Together, these examples highlight differences in field of view, image construction, and clinical utility. Panel A shows a traditional color fundus photograph with a field of view of approximately 50 degrees. This image demonstrates natural color reproduction and clear visualization of the posterior pole, but is limited in peripheral coverage. Panel B shows a confocal scanning laser ophthalmoscopy multicolor fundus image with a narrower field of view of about 30 degrees. Although the color appearance is less natural, this image provides enhanced contrast and detail due to the confocal, laser-based acquisition. Panel C demonstrates an ultra-wide field SLO image obtained using an ellipsoidal mirror system, providing a field of view of approximately 200 degrees. This image captures nearly the entire retina in a single frame, including the far periphery, using pseudocolor generated from red and green lasers. Collectively, these images emphasize how different imaging modalities offer complementary perspectives, reinforcing the importance of selecting the appropriate technique based on the clinical question.
As imaging moves from en-face visualization to cross-sectional analysis, optical coherence tomography has become a central tool in retinal diagnosis. OCT is a non-invasive, non-contact imaging modality that produces micrometer-resolution cross-sectional images of the retina, allowing detailed assessment of retinal and choroidal microstructure. Several OCT platforms are in use. Time-domain OCT acquires data through sequential point-by-point sampling and is now largely obsolete. Spectral domain OCT uses a broad-spectrum light source and provides higher resolution than time-domain OCT, with better axial resolution and lower cost, making it the most commonly used platform in clinical practice. Swept source OCT employs a more complex light source that sequentially scans through successive wavelengths. Compared with spectral domain OCT, swept source OCT offers faster image acquisition, a wider scan range, improved vitreous to choroidal imaging, and better penetration through media opacities. OCT also plays an important role in choroidal imaging. Although swept source OCT provides superior visualization of the choroid, spectral domain OCT can image the choroid effectively using enhanced depth imaging. This capability is particularly useful for measuring choroidal thickness and assessing choroidal involvement in retinal and choroidal disease. Building on the cross-sectional capabilities of OCT, advanced features further enhance both visualization and longitudinal assessment. Volume rendering allows three-dimensional visualization of retinal structures by compiling multiple OCT scans into a volumetric dataset. Although this approach is computationally intensive and not yet widely used in routine ophthalmic practice, it provides a more comprehensive representation of complex retinal architecture.
Eye tracking technology addresses one of the major challenges in OCT acquisition: ocular motion. By detecting and correcting for eye movements, eye tracking improves image quality even in the presence of blinks. It also enables repeat imaging of identical retinal locations over time, which is critical for accurately monitoring disease progression and treatment response. The accompanying figures demonstrate these concepts in a clinical context. Panel A shows a color fundus photograph of an eye with prominent drusen and associated visual distortion. Panel B is an OCT-B scan revealing a lamellar macular hole with associated lamellar hole-associated epiretinal proliferation, highlighted by the arrows. Panel C and D show different views generated from volume-rendered OCT imaging of the same eye, illustrating the thick epiretinal membrane, the configuration of the lamellar macular hole, and cavitations within the undermined retina, while also demonstrating the absence of significant induced retinal distortion. Together, these images highlight the added value of eye tracking and volume-based OCT analysis in characterizing retinal pathology.
Extending the capabilities of structural OCT, OCT angiography provides a non-invasive method for visualizing retinal and choroidal blood flow. OCTA is based on detection of motion contrast by comparing sequential OCT images over time. Stationary tissue demonstrates low signal variance and appears dark, whereas moving blood produces high variance and appears bright. This approach allows depth-resolved visualization of blood flow within specific retinal layers and generates a three-dimensional representation of retinal and choroidal circulation. OCTA offers several key advantages. Because it does not require intravenous dye, it is non-invasive and can be performed more rapidly than fluorescein angiography. OCTA is able to image all capillary layers of the retina, including the superficial capillary plexus, the radial peripapillary capillary network, and the deep capillary complex. In addition, it provides higher spatial resolution of the retinal vasculature than any other currently available imaging modality, making it a powerful tool for evaluating microvascular pathology.
Although OCT angiography provides high-resolution, depth-resolved vascular imaging, it is important to understand how it compares with fluorescein angiography. OCTA cannot demonstrate vascular leakage, which limits its utility in conditions where leakage is a defining feature. As a result, fluorescein angiography remains superior for evaluating diseases such as retinal vasculitis and macular edema. In addition, OCTA has traditionally been focused on imaging the macula, although its field of view continues to expand with newer technologies. Interpretation of OCTA images also requires familiarity with common artifacts. Motion artifacts are caused by eye movement and appear as bright areas that are unrelated to true blood flow. These can be reduced through eye tracking, repeated scans, and software-based correction. Projection artifacts occur when superficial vessels are projected onto deeper reflective layers, creating the appearance of duplicate vessels at multiple depths, and can be mitigated with post-processing algorithms. Finally, dark areas on OCTA may represent absent or very slow blood flow, but because of uncertainty in signal interpretation, these regions are often referred to as signal voids rather than true non-perfusion. These images demonstrate the depth-resolved capabilities of OCT angiography in a healthy eye, highlighting how different vascular layers can be visualized separately and then integrated. Panel A shows the superficial vascular plexus, characterized by larger vessels with a branching fractal pattern surrounding the foveal avascular zone. Panel B illustrates the deep capillary plexus, where the vessels are smaller, more densely packed, and lack the same branching architecture seen in the superficial plexus. Panel C shows the choriocapillaris, which appears as a fine, granular vascular network distinct from the retinal capillary layers above it. Panel D presents a color depth-encoded OCTA image of the macula, in which vessels from different depths are assigned different colors, allowing simultaneous visualization of multiple vascular layers. Panel E extends this concept to a wider fundus view, again using color depth encoding to delineate vessels at each retinal and choroidal level. Together, these images illustrate how OCTA provides layer-specific and three-dimensional information about retinal and choroidal circulation that cannot be appreciated with conventional angiographic techniques alone. Shifting from vascular imaging to metabolic assessment, fundus autofluorescence provides a rapid, non-contact, and non-invasive method for imaging intrinsic retinal fluorophores. The major fluorophores detected on FAF include lipofuscin and bisretinoids, which are located primarily within RPE lysosomes, as well as melanin. During image acquisition, excitation light is delivered to the eye, and the emitted fluorescence is captured using a barrier filter that blocks the excitation wavelength. The biologic basis of FAF imaging centers on changes within the retinal pigment epithelium. Bisretinoids accumulate within RPE cells as part of normal aging. When RPE cell loss occurs, dispersion or absence of lipofuscin leads to hypoautofluorescence, which appears as dark areas on FAF imaging. In the setting of RPE tears, which often occur in association with choroidal neovascularization, scrolled RPE appears hypoautofluorescent, whereas areas of bare underlying tissue demonstrate no autofluorescence. Clinically, interpretation of FAF patterns follow these principles. Hypoautofluorescence indicates increased or concentrated fluorophores, while hypoautofluorescence reflects RPE loss or absence of fluorophores. Together, these patterns provide important insight into RPE health, disease activity, and progression in a wide range of retinal disorders.
Building on the principles of fundus autofluorescence, this slide highlights its key clinical applications. FAF is particularly useful for monitoring geographic atrophy, which appears as well-demarcated areas of hypoautofluorescence, corresponding to RPE loss. Because FAF directly reflects changes in RPE health, it is also well-suited for tracking the progression of RPE loss over time. Fundus autofluorescence also plays an important role in evaluating chorioretinal lesions in posterior uveitis. In this setting, active inflammatory lesions often demonstrate hyperautofluorescent borders, reflecting increased or concentrated fluorophores at the margins of disease activity. The accompanying images illustrate these applications. The image in the upper right shows fundus autofluorescence of a healthy eye, demonstrating a relatively uniform background signal with normal hypoautofluorescence at the fovea due to macular pigment absorption. The lower left image is a color fundus photograph of a patient with choroidal neovascularization and an associated RPE tear, highlighted by arrows. The lower right image is the corresponding FAF image, which shows absence of autofluorescence in areas of RPE loss and increased autofluorescence where the RPE is scrolled. Together, these images demonstrate how FAF can confirm RPE pathology and delineate lesion extent beyond what is visible on color fundus photography alone. In practice, fundus autofluorescence can be performed using either traditional fundus cameras or scanning laser ophthalmoscopes, with important technical differences between the two approaches. Fundus camera-based FAF uses special filters optimized for detection of lipofuscin and is designed to minimize interference from lens autofluorescence, which is partly due to tryptophan and non-enzymatic glycosylation. In this system, excitation is delivered at green wavelengths. Emitted fluorescence is detected in the orange spectrum, and the excitation wavelengths are not absorbed by macular pigment. FAF can also be obtained using scanning laser ophthalmoscopes. Early SLO systems used blue excitation light, which is absorbed by macular pigment and limited image quality. The introduction of green laser excitation overcame this limitation and remains the standard approach, as green wavelengths are not absorbed by macular pigment and allow improved autofluorescence imaging. Additionally, comparison of green light autofluorescence across registered images enables the creation of two-dimensional macular pigment density maps, further expanding the clinical utility of FAF imaging.
Expanding on standard fundus autofluorescence techniques, several advanced FAF modalities provide additional molecular-level information. Near-infrared fundus autofluorescence uses excitation at 787 nanometers with emission detected above 800 nanometers. This approach enables detection of different molecular species. Fluorescence at these wavelengths was initially attributed primarily to melanin within the RPE and choroid. However, lipofuscin can also fluoresce in this range. In addition, molecular cross-linking between lipofuscin and melanin forms melanolipofuscin, which also fluoresces in the near-infrared spectrum. Time-resolved FAF further refines molecular characterization by demonstrating that different molecules may fluoresce at the same wavelengths but at different times following excitation. Phaser-based time-resolved imaging allows in vivo identification of specific molecular species and provides information about cellular redox state, adding a functional dimension to FAF imaging. Hyperspectral FAF represents another evolving approach, measuring fluorescence across multiple wavelengths simultaneously. This technique aims to more precisely characterize molecular composition and fluorophore formation, with the goal of improving understanding of retinal disease mechanisms and progression.
As imaging resolution continues to advance, adaptive optics represents the highest level of retinal imaging currently available. Adaptive optics imaging refers to a collection of techniques that compensate for wavefront aberrations in real time, including aberrations caused by factors such as tear film variability. This technology was originally developed for astronomical telescopes and later adapted for ophthalmic use. By correcting optical distortions, adaptive optics enables visualization of individual retinal photoreceptors and retinal pigment epithelial cells, providing ultra-high-resolution images of retinal microstructure that are not achievable with conventional imaging modalities. Despite these capabilities, adaptive optics has important limitations. Image acquisition is extremely time-consuming and requires expensive, custom-built instrumentation. The technique is technically complex and has limited patient applicability, as it cannot be used effectively in eyes with media opacities or in eyes with intraocular lenses. As a result of these constraints, adaptive optics has seen limited adoption in routine clinical practice and is used primarily in research settings, where its ability to visualize retinal structure at the cellular level offers valuable insight into retinal disease mechanisms.
Transitioning from non-invasive imaging modalities to dye-based vascular studies, fluorescein angiography, or FA, is crucial in ophthalmology for visualizing retinal blood flow, diagnosing and monitoring conditions like diabetic retinopathy, macular degeneration, and vascular occlusions, and guiding treatment by showing leaks, blockages, or neovascularization that other imaging, like OCT, might miss, revealing the dynamics and integrity of retinal and choroidal circulation. This modality assesses retinal blood flow using rapid serial photography following intravenous injection of fluorescein dye. The dye is administered through an antecubital vein, typically as 2 to 3 milliliters of 25% fluorescein or 5 milliliters of 10% fluorescein. Fluorescein angiography is traditionally performed using a fundus camera or scanning laser ophthalmoscope, providing a field of view of approximately 50 degrees. Increasingly, wide-field systems are being used to image a much larger portion of the fundus, including the peripheral retina, expanding the diagnostic utility of this technique. Image acquisition relies on specific optical filters. Fluorescein appears yellow to orange-red depending on concentration. Excitation is provided by blue-green light in the range of 465 to 490 nanometers, while emitted fluorescence is captured using a barrier filter that transmits yellow light between 520 and 530 nanometers, corresponding to fluorescein's peak emission. This barrier filter blocks all other wavelengths, isolating the fluorescein signal. Finally, key properties of fluorescein influence image interpretation. Approximately 80% of fluorescein is protein-bound in the circulation, and under normal conditions, the blood-retina barrier prevents it from diffusing into retinal tissue. These characteristics form the basis for detecting abnormalities, such as leakage, non-perfusion, and breakdown of the blood-retina barrier on fluorescein angiography.
After dye injection, fluorescein angiography progresses through a predictable sequence of phases that reflect retinal and choroidal blood flow over time. The first phase is the choroidal flush, which occurs approximately 8 to 12 seconds after injection and represents filling of the choroidal circulation, seen in Figure A. This is followed by the arterial phase, during which the retinal arterioles begin to fill, typically between 11 and 18 seconds after injection. Shortly thereafter, the early arteriovenous or laminal phase occurs 1 to 3 seconds later. In this phase, fluorescein can be seen layering within the retinal veins, with brighter dye along the vessel walls and relatively darker blood centrally, as shown in Figure B. The venous or complete arteriovenous phase follows, characterized by full venous filling over the next 5 to 10 seconds, seen in Figure C. As circulation continues, the study enters the recirculation, or mid-phase, which occurs approximately 2 to 4 minutes after injection. During this phase, dye remains within the retinal vasculature, but begins to gradually diminish. Finally, the late phase occurs around 4 to 5 minutes after injection, and is marked by progressive elimination of fluorescein from the bloodstream, with an overall decrease in vascular fluorescence, as shown in Figure D. As fluorescein angiography progresses, careful attention to choroidal and foveal findings provides important diagnostic information.
The choroid may fill in a non-uniform pattern. If areas of the choroid remain unfilled by the time the retinal circulation has reached the laminar flow phase, this indicates abnormal choroidal filling. Once fluorescein reaches the choriocapillaris, the dye leaks freely and stains Bruch membrane and the choroidal stroma. This leakage rapidly obscures fine choroidal detail, which explains why assessment of choroidal perfusion is limited to the earliest phases of the angiogram. In contrast, delayed initial filling of the retinal circulation is most commonly associated with retinal vascular occlusive disease. The fovea has a characteristic appearance on fluorescein angiography, appearing darker than the surrounding retina. This relative hypofluorescence is due to absorption of excitation light by macular pigment, increased melanin content within taller RPE cells at the fovea, and the absence of retinal vessels within the foveal avascular zone. Together, these features create the normal dark foveal appearance seen on fluorescein angiography.
When interpreting fluorescent angiography, abnormalities are broadly categorized into two main patterns, hypofluorescence and hyperfluorescence. Understanding the mechanism behind these patterns is essential for accurate diagnosis. Hypofluorescence refers to reduced or absent normal fluorescence and occurs through two primary mechanisms. The first is a vascular filling defect, in which retinal or choroidal vessels fail to fill due to intravascular obstruction, resulting in non-perfusion. This appears angiographically as delayed or absent filling of the affected vascular territory. The second mechanism is blocked fluorescence, in which normal fluorescence is obscured by overlying material such as blood, pigment, or fibrous tissue. In these cases, lesion depth can be inferred by evaluating the visibility of retinal vessels. If retinal vessels remain visible over a dark area while the underlying choroidal fluorescence is blocked, this suggests that the lesion is located between the retina and the choroid.
In contrast to hypofluorescence, hyperfluorescence refers to abnormally increased fluorescence that extends beyond normal anatomic boundaries. Recognition of the specific pattern of hyperfluorescence is critical, as it reflects the underlying pathophysiologic process. There are four classic patterns of hyperfluorescence seen on fluorescein angiography: leakage, staining, pooling, and window defect, which we will talk about individually in the upcoming slides. Distinguishing among these patterns provides essential diagnostic insight when interpreting fluorescein angiograms. Focusing on the first pattern of hyperfluorescence, leakage is characterized by a gradual increase in both intensity and size of fluorescence over time. This progressive spread reflects active extravasation of dye beyond normal anatomic boundaries. Leakage occurs due to breakdown of the blood-retina barriers. Disruption of the inner blood-retina barrier allows fluorescein to leak into the retinal tissue, including cystoid spaces and fibrotic tissue. Breakdown of the outer blood-retina barrier at the level of the retinal pigment epithelium permits dye to accumulate within the subretinal space. As leakage progresses, the borders of hyperfluorescence become increasingly indistinct. The accompanying angiographic image demonstrates these features in a clinical context. The image shows fluorescein leakage associated with cystoid macular edema, producing a characteristic petaloid pattern as dye accumulates within the cystoid spaces of the macula.
Another pattern of hyperfluorescence is staining, which differs from leakage in both behavior and appearance over time. In staining, fluorescence intensity increases and persists into the late frames of the angiogram, but the size and borders of the hyperfluorescent area remain well-defined and sharp. Staining occurs when fluorescein enters and binds within solid tissue rather than freely diffusing into fluid spaces. Common structures that demonstrate staining include scar tissue, drusen, vessel walls, optic nerve tissue, and the sclera. Because the dye remains confined within these tissues, there is no progressive blurring or expansion of the borders. The accompanying angiographic image illustrates this pattern. The image shows late staining of plaques associated with acute multifocal posterior placoid pigment epitheliopathy, demonstrating persistent hyperfluorescence with sharply demarcated borders, consistent with staining rather than leakage. Pooling represents another classic pattern of hyperfluorescence and occurs when fluorescein accumulates within a fluid-filled space.
Unlike leakage, the dye does not spread beyond the boundaries of the space, but instead becomes trapped, leading to a progressive increase in fluorescence within a confined area. As pooling progresses, the margins of the hyperfluorescent area become increasingly well-defined, reflecting the anatomic limits of the fluid-filled compartment. A classic example of pooling is seen with retinal pigment epithelial detachment in central serous chorioretinopathy, where fluorescein collects beneath the elevated RPE. The accompanying angiographic image demonstrates this pattern, showing well-circumscribed hyperfluorescence due to pooling of dye within a serous pigment epithelial detachment, with sharply defined borders corresponding to the boundaries of the detached space.
The final classic pattern of hyperfluorescence is the window or transmission defect. This occurs due to loss or thinning of retinal pigment epithelium pigment, which normally blocks underlying choroidal fluorescence. When the RPE is attenuated or absent, normal choroidal fluorescence becomes more visible. A window defect appears early in the angiogram and is brightest during peak choroidal filling. Unlike leakage or pooling, it does not enlarge over time and gradually fades in the late phases. Importantly, the dye remains confined to the choroid and does not leak into the retina. The accompanying angiographic image demonstrates this pattern in geographic atrophy from age-related macular degeneration. The areas of RPE loss allow increased transmission of choroidal fluorescence, producing well-demarcated early hyperfluorescence that fades without expansion, consistent with a window defect rather than active leakage. In clinical practice, multiple fluorescein angiographic abnormalities often coexist within the same eye, and interpretation requires integrating several patterns simultaneously. Choroidal neovascularization is a classic example in which more than one angiographic abnormality is typically present. In eyes with CNV, there may be segmental delay in choroidal filling, reflecting underlying choroidal perfusion abnormalities. Early in the angiogram, neovascular tissue often demonstrates hyperfluorescence due to rapid filling of the abnormal vascular network. As the study progresses, this is followed by late leakage from the choroidal neovascularization, and in some cases, areas of late staining are also present, reflecting dye retention within associated tissue components. The accompanying angiographic sequence illustrates these combined findings. Panel A shows delayed choroidal filling, with only a few choroidal vessels containing dye by the time fluorescein reaches the central retinal artery. Panel B demonstrates the early laminar phase, in which a large portion of the choroid still shows poor filling. Panel C shows the arteriovenous phase, with more uniform filling of the choriocapillaris and clearer visualization of a network of choroidal neovascular vessels in the central macula. Panel D represents the late phase, revealing leakage surrounding the earliest filling neovascular vessels, consistent with classic CNV, indicated by arrowheads. In addition, there is late staining and mild leakage from a less well-defined region, marked by an arrow, consistent with occult CNV. Together, these images emphasize that multiple fluorescein angiographic patterns frequently overlap in complex retinal disease.
This is an early phase angiogram of a patient with a central pigment epithelial detachment. At approximately 11 seconds, there is choroidal flush, followed shortly thereafter by arterial filling, and then laminar venous flow, and finally full venous filling. Supranasal to the fovea and within the area of the pigment epithelial detachment, there are circular hyperfluorescent lesions that appear and then slowly leak as the angiogram goes on. These indicate the areas of the polypoidal lesions.
To consolidate the fluorescein angiography patterns just discussed, this table summarizes the key differences in brightness and size over time among the four classic hyperfluorescence patterns. Focusing on how these features evolve as the angiogram progresses helps distinguish one pattern from another in practice. With leakage, both brightness and size increase over time, reflecting progressive spread of dye beyond normal boundaries. In staining, brightness increases, but the size does not change. Instead, the hyperfluorescent area maintains fixed borders with an often irregular shape. Pooling is characterized by brightness that stays the same or increases, while the size remains unchanged and conforms to a regular, round, or oval shape dictated by the fluid-filled space. In contrast, a window defect shows decreasing brightness over time, with no change in size, as early transmitted choroidal fluorescence fades in later phases. Together, this table provides a concise visual framework for comparing hyperfluorescence patterns based on temporal changes in intensity and size, reinforcing the systematic approach needed for accurate fluorescein angiography interpretation.
Before concluding the discussion of fluorescein angiography, it is important to review its potential adverse effects. Most reactions are expected and common. These include transient yellowing of the skin and conjunctiva lasting 6 to 12 hours. Nausea and vomiting occur in approximately 5% of patients and are typically brief and self-limited. Urticaria, also occurring in about 5% of cases, is usually managed with diphenhydramine. More serious reactions are rare but clinically significant. These include hypotension, shock, and laryngeal spasm. Death is extremely rare, with an estimated incidence of approximately 1 in 222,000. For this reason, a physician must be present during fluorescein angiography, and a crash cart should be readily available. Certain factors increase the risk of adverse reactions. A prior urticarial reaction raises the likelihood of recurrence, and premedication with antihistamines and/or corticosteroids may reduce risk in selected patients. Extravasation of fluorescein into the skin can cause pain and swelling, and is managed with ice-cold compresses for 5 to 10 minutes, with close follow-up until symptoms resolve. Special populations also warrant consideration. Although no proven teratogenic effects have been identified, fluorescein angiography is often avoided during the first trimester of pregnancy unless essential. In addition, fluorescein is excreted in breast milk, which should be considered when imaging lactating patients.
Moving from fluorescein angiography to imaging of the choroidal circulation, indocyanine green angiography is specifically optimized for choroidal visualization. Indocyanine green is a water-soluble tricarbocyanine dye with limited diffusion through the fenestrations of the choriocapillaris. Because it remains largely within the intravascular space, it has high intravascular retention, making it particularly well suited for imaging choroidal vasculature. From a metabolic and optical standpoint, indocyanine green is metabolized by the liver and excreted in bile. Imaging is performed using near-infrared wavelengths, with excitation between approximately 790 and 805 nanometers, and emission between 825 and 835 nanometers. Near-infrared light penetrates the retinal pigment epithelium and ocular pigment more effectively than visible light, allowing improved visualization of deeper choroidal structures. As a result of these properties, the key advantage of indocyanine green angiography is its superior ability to visualize the choroidal circulation, compared with fluorescein angiography, particularly in conditions where pathology is primarily choroidal in origin.
To further illustrate indocyanine green angiography, this slide presents wide-field ICGA images of a healthy eye across different phases of the study, highlighting how choroidal visualization evolves over time. Panel A shows the early phase of ICGA, characterized by the initial appearance of indocyanine green within the choroidal circulation. In this phase, large choroidal arteries and veins are clearly visible, and portions of the retinal vasculature can also be seen. The prominence of the choroidal vessels reflects the strong intravascular retention of ICG and the enhanced penetration of near-infrared light. Panel B represents the middle phase, occurring approximately 5 to 15 minutes after injection. During this phase, the choroidal veins become less distinct, and a more diffuse, homogeneous choroidal fluorescence is observed. Hyperfluorescence of the retinal blood vessels is diminished, shifting emphasis toward the broader choroidal circulation. Panel C demonstrates the late phase of ICGA, which occurs around 15 minutes after injection. At this stage, there is reduced visibility of both retinal and choroidal vascular detail, with more uniform background fluorescence and fading of earlier vascular patterns. Together, these images emphasize the phase-dependent information provided by ICGA and its strength in assessing choroidal circulation over time. With an understanding of its imaging properties, indocyanine green angiography is best appreciated in the context of its clinical indications. One of its major uses is in the evaluation of choroidal neovascular disease, particularly polypoidal choroidal vasculopathy, which represents a common form of CNV. ICGA is also valuable for assessing type 3 neovascularization, also known as retinal angiomatous proliferation, and for detecting asymptomatic choroidal neovascularization in patients with drusen. ICG angiography is especially useful in inflammatory and choroidal diseases, particularly when performed with ultra-wide-field imaging. It plays an important role in conditions such as birdshot chorioretinopathy and multifocal choroiditis with panuveitis, where choroidal involvement may be difficult to appreciate with other modalities. In central serous chorioretinopathy, ICGA can demonstrate multifocal areas of choroidal vascular hyperpermeability, providing insight into the underlying choroidal pathology. It is also important to recognize evolving practice patterns. In some settings, the role of ICGA in uveitis and central serous chorioretinopathy has been partially supplanted by fundus autofluorescence combined with enhanced depth imaging OCT, reflecting the growing use of non-invasive multimodal imaging in retinal and choroidal disease. To illustrate one of the key indications for indocyanine green angiography, this slide focuses on polypoidal choroidal vasculopathy. This condition represents a common form of choroidal neovascular disease in which pathology arises primarily within the choroidal circulation and beneath the retinal pigment epithelium, making ICGA particularly valuable. Panel A shows a color fundus photograph demonstrating characteristic clinical features of polypoidal choroidal vasculopathy. There is an area of lipid exudation surrounding a hemorrhage, along with prominent orange-colored subretinal vessels. An area of decreased pigmentation is also visible inferotemporal to the optic nerve, suggesting underlying choroidal pathology that is not fully defined on color photography alone. Panel B shows the corresponding indocyanine green angiography image. In contrast to the fundus photograph, ICGA clearly delineates the abnormal sub-RPE vascular network, revealing the polypoidal lesions and associated branching choroidal vessels. This comparison highlights the strength of ICGA in visualizing choroidal vasculature and explains why it is the preferred imaging modality for diagnosing and characterizing polypoidal choroidal vasculopathy.
This is the early phase indocyanine green angiogram of a patient with a retinal pigment epithelial detachment. You will see dye enter the choroidal circulation at approximately 10 seconds. The pigment epithelial detachment is centrally located and dark. Attention is drawn to the supranasal area within the pigment epithelial detachment, where dye fills the circular structures and then leaks over the course of the angiogram. This indicates the areas of polypoidal lesions within the choroid.
As with any dye-based angiographic study, it is important to be aware of the potential adverse effects of indocyanine green angiography. Mild adverse events are uncommon, occurring in less than 1% of patients. Indocyanine green dye is dissolved in 5% sodium iodide, which has implications for patient screening. Allergy considerations are particularly important. An iodine allergy is considered a relative contraindication to ICGA angiography, whereas a shellfish allergy does not contraindicate ICG use. Facilities performing ICGA should have appropriate emergency protocols in place to manage rare but serious complications, including anaphylaxis. Systemic factors must also be considered. Indocyanine green is metabolized by the liver, and in patients with liver disease, the dye may persist longer in the bloodstream. For this reason, ICGA requires added caution and clinical awareness when used in patients with underlying hepatic dysfunction.
When media opacity limits direct visualization, ultrasonography becomes an essential adjunct in retinal and choroidal evaluation. B-scan ultrasonography is the most commonly used ophthalmic ultrasound modality and is performed using a 10 MHz probe placed on the closed eyelid. A piezoelectric crystal within the probe generates and receives sound waves to create a two-dimensional image of intraocular structures.
At the level of the retina, the ultrasound beam is approximately 1 millimeter wide, which results in limited lateral resolution. Axial resolution in the eye also differs from that of flat surfaces due to the curved ocular anatomy and signal summation effects, factors that must be considered when interpreting images. Despite these limitations, B-scan ultrasonography has a wide range of clinical applications. It is used to measure intraocular tumor thickness, detect intraocular foreign bodies, and evaluate retinal and choroidal detachments. It is also useful for analyzing vitreous pathology, identifying optic disc drusen based on their characteristic bright reflectivity with acoustic shadowing, and with careful technique, detecting retinal tears.
One of the major advantages of B-scan ultrasonography is its ability to provide dynamic imaging. Because ultrasound does not rely on pupillary dilation or optical clarity, imaging can be performed during eye movements, including saccades. This dynamic assessment is particularly helpful for evaluating vitreous opacities and for distinguishing retinoschisis from a true retinal detachment based on differences in mobility and configuration with eye movement. In terms of overall strengths and limitations, B-scan ultrasonography remains highly effective in the presence of opaque media, such as dense cataract or vitreous hemorrhage, where other imaging modalities may fail. However, image quality is reduced when intraocular gas or silicone oil is present, as these substances attenuate the ultrasound signal. Understanding these strengths and limitations helps guide appropriate use of ultrasonography in the diagnostic evaluation of retinal and choroidal disease.
Today we will demonstrate exam techniques for evaluating the posterior segment using a 10 megahertz B-scan probe. Our first cut in the protocol will be the horizontal axial cut. The probe marker will be positioned nasally, with the probe positioned over the apex of the cornea. You'll be able to view lens status, as well as anatomical structures, the optic nerve, the macular region, and the extraocular muscles. Our next image in the protocol is the vertical disc. So you move the probe off to the limbal region. Probe marker is superior, with the nerve centered in the middle of the screen. We're going to bypass the lens to reduce artifacts, to properly evaluate the nerve and assess cupping, drusen, and other optic nerve pathologies. Keeping your probe marker superior, we move back over the apex of the cornea for our vertical macula cut. Crystalline lens in front of the screen, centering the macula in the posterior. The hyperreflectivity on the screen shows that you're parallel with the structures you're examining. Now that we've imaged the posterior pole, we can look at 4 quadrants. So first we'll look nasally, keeping the probe marker superior. Direct the patient's gaze nasally. The probe marker positioned in the limbal region. Sweeping anterior to posterior to evaluate the nasal quadrant. Landmarking at the widest volume of the globe. Keeping your probe marker superior, we'll evaluate the temporal quadrant. Will be reversed, so we'll have you look to your left. In the limbal region now, sweeping temporally, anterior to posterior. Landmarking at the widest volume of the globe. Now to evaluate the inferior quadrant, we'll rotate the probe marker nasally, directing the patient's gaze inferior positioning the probe in the superior portion of the globe, sweeping anterior, posterior. And now to evaluate the superior hemisphere, keeping the probe marker in the nasal position, have the patient direct their gaze superior. Probe is positioned in the inferior aspect of the globe, sweeping anterior to posterior. Using those 7 images, you're able to evaluate the entirety of the globe.
In this patient with kissing choroidal detachments, both clotted and liquefied blood are shown to be swirling around as the patient moves their eye. This B-scan ultrasound shows an ovoid preretinal interface consistent with a fallen crystalline lens that is non-mobile upon kinetic scan. It is surrounded by mobile, loose, and membranous vitreous debris.
Moving from posterior segment ultrasound to higher resolution anterior imaging, ultrasound biomicroscopy uses very high frequency ultrasound, approximately 50 MHz. This higher frequency provides excellent spatial resolution, but at the expense of decreased tissue penetration depth. The probe is placed in a water-filled cup that contacts the eye, allowing detailed visualization of anterior segment structures. Ultrasound biomicroscopy is best suited for imaging the anterior segment, including the anterior chamber, ciliary body, and the anterior vitreous insertion. Because of its high resolution, it is particularly useful for evaluating structures that are difficult to visualize with slit lamp examination alone. Common clinical applications of UBM include assessment of anterior segment tumors, iris cysts, and intraocular foreign bodies. It is also valuable for identifying cyclodialysis clefts, anterior suprachoroidal effusions, and for evaluating intraocular lens position and the presence of hyphema.
This wraps up the second chapter of the Retina section. This chapter outlined a systematic diagnostic approach to retinal and choroidal disease, beginning with clinical examination and extending through a range of complementary imaging modalities. By integrating findings from ophthalmoscopy, multimodal imaging, angiography, and ultrasonography, clinicians can accurately localize pathology, characterize disease activity, and guide appropriate management decisions. Great job on completing this. We'll see you in the next chapter.